Hello, everyone, and welcome to our Monday Night IBD consult break with the expert. Today, we will be talking about short bowel syndrome in the pediatric population. This series is supported by an educational grant from Takeda. I'm Dr. Ali Sharabadi, the founder of Monday Night IBD and the clinical director of the IBD Center at Johns Hopkins Sibley Memorial Hospital. I'm joined today by my colleague and very good friend, Dr. Valerie Koren. Dr. Koren is an associate professor of pediatrics at Northwestern University Feinberg School of Medicine. She is the medical director of intestinal rehab and transplantation at Lurie Children's Hospital. Dr. Koren, welcome.
Thank you. Thank you, Dr. Cherabati and Monday Night IBD for having me for the special event tonight.
Well, we are very excited to have you too. Our faculty disclosures are on the screen. And let's get started. I'm actually very excited by today's topic, and I'm very excited to have you with us because short bowel syndrome is a topic that is often under-addressed during GI training and in GI meetings. And when we have something we're not familiar with, it becomes difficult and challenging for us to recognize it and to treat it appropriately. So thank you so much, Dr. Koren, for being with us today and talking about how we define short bowel syndrome, how to anticipate it in a specific patient, how common is this happening in children, and how to recognize it, make the right diagnosis, and then proceed to the right therapy and management. So let's start with the definition of short bowel syndrome, or when should we anticipate that a child or an infant that is undergoing surgery, when should we anticipate that this is a child at risk of having short bowel syndrome? So let's prepare for that.
So I think commonly when we think about children who develop short bowel syndrome, we think about those infants in the NICU. And those infants in the NICU may have a congenital abnormality such as gastroschisis. They may go on to develop what we know as necrotizing enterocolitis, which affects significantly low birth weight infants. And those patients may undergo surgical resections. So as a result of those resections, some of those infants may not be able to absorb everything through their intestine. So they may require IV or TPN to help sustain them. If you're unable to absorb from your intestine, your nutrients, your fluids, your electrolytes, your vitamins and minerals are all need to be provided an alternative way, and that's through TPN. When you think about perhaps older children or even adults who may have had a history of a resection previously, and perhaps it's not known how much bowel they have or they're missing, those may be patients who may be having significant diarrhea. They may be having growth failure. They may have vitamin and mineral deficiencies, and it's unclear why. So those are patients, though, even though they don't quote unquote have a central line, those are patients who potentially are demonstrating symptoms of short bowel syndrome. When we think about the NICU population, unfortunately, we don't have great data on that. But what we do know, the incidence of short bowel syndrome in one study has been as many as 22.5 infants per 1,000 live births. And so I think as we have more and more premature infants that are surviving, we're perhaps seeing more instances of NEC, for instances, or we're seeing children who may have other types of intestinal failure that are leading them to need TPN for a prolonged period of time. When I think about short bowel syndrome, I do think of patients typically as requiring IV nutrition, TPN, or IV fluids. But as I said before, their patient may present later in life with symptoms, and maybe it's not clear what resections they had or did not have, but if they're having symptoms like diarrhea, weight loss, electrolyte derangements, that's a diagnosis that should be considered.
That is fantastic. I'm thinking as you're talking, I'm thinking as an adult GI. So what are the diagnoses that we should think of and that would trigger a bulb for us adult GI? What kind of event in someone's childhood should make us be more wary that if I send this patient to the next surgery, then I'm putting that patient at risk of short bowel syndrome, so I need to be prepared for that?
I think probably, necrotizing enterocolitis is the most common cause of short bowel syndrome in pediatrics. So I think having a child who has a remote history of NEC as an infant would be one. I think gastroschisis, intestinal atresias, volvulus. I think anytime you've had a patient that has had some type of surgical resection, I must admit, we don't see Crohn's disease in pediatrics causing short bowel syndrome as much because of some of the biologic agents that we're able to use now. But I do think if the child has had a previous resection, perhaps they're very low on their growth curve, maybe diarrhea, like I said, some electrolyte derangements or vitamin mineral deficiencies, that's a patient I would worry that may have some complications after this next surgery, and that may lead to TPN need or utilization afterwards.
Before we go into treatment, I have a few more questions for you. And I know this is what you do day in, day out. And so this is very familiar for you. I think for most of us that didn't get a deeper training in short bowel syndrome or didn't get the opportunity to see patients with short bowel syndrome, I think in our mind, we think about, if I think of it, I will think about someone who's malnourished, losing weight, diarrhea all day. But I imagine that's not all patients. So what are the more kind of subtle or symptoms where we should think this is short bowel syndrome and not just plain diarrhea with some electrolyte abnormality? What is the spectrum we're talking about here, and when should we recognize it outside the time where it's just screaming at us, this is short bowel syndrome?
I think sometimes we get mistaken when we hear patients, or we ask patients the question, how many stools do you have a day? And the patient may say, I have 3 stools a day. And that may or may not trigger something, but asking, what is the consistency of the stool? How much volume is in actually the stool? Are you filling up the toilet with stool? And I think sometimes that may get missed unless you kind of drill down a little deeper into this patient's history. Also, do you get abdominal distension? Do you feel like you have some abdominal pain? Are there times where you're really bloated? Now, you can think of some of those symptoms with other diseases, like maybe lactose intolerance. But, if that patient has a distant history of a surgical resection, perhaps that should clue you in that maybe there's something more than that that's actually going on. Looking at their growth, ask them how they compare to their siblings if they have them with regard to growth. I've seen patients who the siblings are all 6 feet tall, and then this patient's 5'6". And so, if there's something, genetics happens, genetic height is predicted by your parental height. And so if everybody's tall in the family and this person's not so tall, maybe that's something else you should look at. So I think previous growth history, maybe drilling down a bit more on the stools, looking at vitamin mineral deficiencies. Yes, you can have abnormal electrolytes when you have looser stools, but does that necessarily mean your vitamin D is very low? Are there more chronic things that you need to look for instead of just thinking, well, maybe it's just they had acute diarrhea. If their vitamin D is 8, let's say, that didn't happen because they had diarrhea for a week. Okay. So thinking about some of the different vitamin mineral deficiencies also should come into play.
Does it, just a quick question, does it affect puberty development, having short bowel? Is it something also that should trigger something in us?
Definitely. If you've seen a patient, and sometimes they're fine early on, and they're able to be tapered from their TPN, but then they hit adolescence. And so in adolescence, especially going through puberty, you need a lot more calories. And so if you're not providing those calories, it is common to see growth delay. I mean, you see that in Crohn's disease when you have younger kids, but you can also see this in perhaps some unrecognized short bowel syndrome. What else is going on while this kid isn't absorbing? And perhaps they're having more malabsorption than what you thought they were actually having from before. I think sometimes it's very clear. They had a prolonged history of TPN usage. Typically, we have the surgeons tell us how much length is left. Length is so important in this also. And so for an adult, it may be 15 feet of small bowel, about 500 or so centimeters. When you think about a neonate or an infant, the intestinal length is about 200 centimeters. And so when I'm hearing a child has, 100 centimeters of bowel, I'm not as concerned, having said, because they only have less than half of what their bowel that they need. And for a kid, that could be more than enough bowel. Not to say they may not have symptoms, but in theory, most of those kids should be tapered from TPN. Whereas an adult who may have only 100 centimeters, that really is what thought to be the cutoff. 100 centimeters will be enough or sufficient for them to be able to absorb enterally and to be able to get all their nutrients. Now, it really depends on the quality of the bowel that's left. So definitely growth failure, delay in puberty are some things that may trigger you to think there's something else going on and there may be more malabsorption than I think.
This is really good because honestly, as you're talking, my anxiety about short bowel syndrome, recognizing it is decreasing somewhat, because I think, and putting back my IBD hat, it's very similar, right? We have to think about, who is the patient at risk? Did they have a catastrophic event as a child, or are they having catastrophic event and going surgery? So anticipating that, recognizing the symptom of short bowel syndrome, which are kind of very similar to small bowel problems, right? So, anywhere from the GI symptoms, the diarrhea, the weight loss, etc., but also the systemic symptoms. So, failure to thrive, puberty being affected, probably fatigue, and then the electrolytes. So I like the fact that, the way you're thinking of workup, and and then what to look for, the operative report, the radiology, radiologist can help, again, communicate that information with the radiologist, and then what kind of workup we can do in terms of electrolyte abnormality, vitamin deficiency, et cetera. And then moving forward, so, the next question is treatment, obviously. What can we do and manage as general GI? When to refer to a small bowel center, and when is the next step? So what are the things that we can start with and be comfortable with? And what are medical therapies available for the kind of the next level, the up level? And then when should we refer our patient to a short bowel center and intestinal rehab center?
I think that's a great question. I think, unfortunately for myself and other colleagues, there are not a lot of adults who enjoy taking care of short bowel syndrome. And so I have colleagues that may have 30-year-old patients, 40-year-old patients, because they're not no adult colleagues to manage these patients. So I again, thank you for allowing me to be here, because I hope someone may feel a little bit more comfortable managing these patients.
That's interesting, because we often talk about peds to adult transition IBD, and now so you have the short bowel is like the reverse transition. Like, we need the pediatric gastroenterologist to tell us what to do. All right. Please continue. This was like, I was thinking, okay, this is a situation where it's like reverse transition happening, but you're right. We do need more adult, but I would love to hear from your experience and what can we do?
So I think when you're thinking about treatment for infants and for children, it's different in the sense that a lot of these kids unfortunately have oral aversion. They have eating disorders, or rather feeding disorders. When you've been sick in the intensive care unit and you've had prolonged intubation, you've had a lot of tubes, these kids very easily get feeding disorders and they don't want to put anything in their mouths. And so we use G-tubes probably a lot more frequently than my adult colleagues do with these patients. And so our main goal is to be able to taper this patient off TPN. So if they're eating it by mouth or combination through a G-tube, that is our ultimate goal. We definitely try to help patients with intensive therapy, with speech, to try to get them to take as much as possible. But sometimes, if you're having a significant amount of diarrhea with eating by mouth, you may require some additional tube feedings, for instance. I think looking to see how much stool the patient is having is so important. And that's, easier to do in an adult to measure their stool versus for kids, we have to assess what's in their diaper. So we actually sometimes have families measure and weigh their diapers and guesstimate for us how much stool is in there. So looking at their electrolytes, they may need extra sodium. And we mentioned that a little bit before. Some of these kids are, especially if they have ileostomies or jejunostomies, that effluent is anywhere from normal saline to half normal saline. So they may, whereas the average person may need 2 to 4 milliequivalents per kilo of sodium, some of these patients are getting 10, 15, 20, 30 milliequivalents per kilo. So you may need to add extra salt to help them, especially for kids, as we worry about growth, because their growth can be delayed if they have sodium depletion. What formula? What are they eating? So for us, sometimes we may use amino acid-based formula or hydrolyzed formula. I think for the adults, they may have more hyperphagia. They may be eating more. And definitely, I know the G-tubes aren't as common, but what exactly are they eating? We do know that carbohydrates can cause worsening diarrhea. So is there a way to do a diet that works for that adult patient where they can eat and they can still gain weight? Fat-containing formulas or fat-containing foods, you get more calories per gram versus carbohydrates, and you have less diarrhea with it. So that's one way to also think about it. So what's in the diet? How much replacement fluids do they need? How much are they losing? So do they need to be drinking, especially in the adult population? How much hydration fluids do they need? In pediatrics, we typically will put that through a tube, although sometimes the children may actually drink that by mouth, but they tend to be very salty solutions. And so, salt water doesn't taste so good. So looking at their electrolytes, and definitely if you're on TPN, you're paying attention to those electrolytes and adjusting their TPN as needed. Sometimes using fiber products is beneficial, and soluble fiber specifically. So soluble fiber is broken down into short chain fatty acids, and those short chain fatty acids help with water and sodium reabsorption in the colon. So that's another way. So what fiber content are they eating, or what type of fibers in their formula? So that to help decrease, because all of this, for most of these patients, the main symptom is the diarrhea. So you've got to replace all that fluid that's getting lost. What other therapies? Slowing down intestinal transit. So that may be using anti-motility agents such as loperamide, for instance. I mentioned using the soluble fiber to kind of help buck up the stools. Immediately post-op, some of the patients may need more antacids because they tend to have gastric hypersecretion after surgery. So that may also be helpful. I think that when we think about drugs for these patients, there's really just one drug at this point that's FDA approved for patients who have intestinal failure, and that's teduglutide. And so I think that in certain instances, that may be also an option for patients you're unable to taper from TPN. Teduglutide is probably going to be used within the context of a multidisciplinary center. So if those patients are losing their access, there are only so many access points, and unfortunately, you can see children and adults die because they don't have enough access. I think sometimes people knee jerk, they have a line infection. Let's pull this line. That may not be the best thing to do. The patient may thrombose at that line. They may lose that line site, and then you're down one. And the more line sites you go down, the less likely you're going to be able to potentially provide TPN. And then that's a patient you're potentially talking about going on to transplant. So I think very conscientious use of the central line. People need to be very clear how to take care of a central line, and consider, let's try and think, are they prophylactic regimens we can use antibiotic wise? Are there locks that we can use to save these lines? If someone's having multiple line infections, I always worry, are they dilated? When you think about dysmotility in some of these patients, especially those patients potentially who have gastroschisis, and even those who don't, you have so much bacteria in your intestine. And what'll happen is, because it's dilated, maybe the bowel's not moving as well, bacteria is just sitting there, and it's growing and it's growing, and it can translocate, and that can end up with some of these patients having line infections. So frequent line infections, I have a low threshold to get contrast studies, upper GI specifically, to look to see, is that bowel dilated? Is this a patient who's not been advancing on feedings and somebody we need to consider some type of tapering procedure? So also liver disease. If you have a patient who has significant liver disease, and it's worsening, you need to consider earlier rather than later, because once you've reached the point where that patient has cirrhosis, there is no turning back at that point, and that patient may need a combined transplant. When you look at pediatric intestinal transplants, for instance, they really peaked in 2011, about 120 or so, maybe a little less. But since then, and a part of this is from our management styles, we have more multidisciplinary teams. We use different types of lock prophylaxis for these patients. I think that we use different types of formulas. So whatever it is, we don't need as many liver intestinal transplants and even isolated intestinal transplants, but we still have patients that will go on to need transplant. And I think right now, the leading indication, underlying indication for intestinal transplant right now is loss of access. So I think, if you're having trouble, you're pulling a lot of lines, that's somebody you need to send. Is it somebody who has bad liver disease or liver disease is worsening? Don't wait till the patient's bilirubin is 10, 15, or 20, because there may not be a turning back. Some of these liver diseases in these patients may not be typical as we think of when we may see a cirrhotic patient for biliary atresia or some other type of liver disease.
Wow. So I think what we need to do after this one is set up another video, because I think the one part I would like to delve more into is that what are the complications that we could see in patients with short bowel syndrome and how to recognize it. And also would love to hear your thought about how, a multidisciplinary approach is needed and what kind of team you need to have. But I want to go back to ductile and just from a standpoint of a general GI or a gastroenterologist interested in IBD or, anyone, what would be the indication and how would you get it started on this drug?
So, the patient who is just stuck, that patient who's really plateaued on their enteral advancement, who still needs IV fluids, who does not seem to be making any progress despite all of your efforts, despite their efforts, that's a patient you should consider potentially using Gattex on. I think some of it really depends upon you're being comfortable with using the drug. You do have to go through the company to use that drug. There's actually an educational program that they will provide for potential prescribers for this drug, and they will meet with you and they will talk with you about it. Fortunately, they do have a program that'll help with your insurance prior authorizations and getting it approved through the company. When we did the 24-week trial for pediatrics, the main outcome was looking at the percentage of patients who had a 20% or greater reduction in their TPN needs. It may not seem like a lot, but that could be a day a week or hours a day that are actually taken from a patient. So, and allowing those patients hopefully to be able to adapt, which is the whole goal of any and all of our therapy, for these patients eventually to be tapered from TPN. I think that the company is supportive and they make sure that the family has information, and their website is very helpful. And I always give families, when I hear that families want to talk about it, I provide them with that information, and then we'll come in and we'll have a clinic visit, a telemed visit, and we'll have an in detail conversation about that drug, because it is a daily sub-Q injection. And for some families, that's fine. For some families, that may be an issue. For some children, that may be an issue, but it's the only FDA approved drug we have in pediatrics, and perhaps also in adults for patients who have short bowel syndrome.
I have one more question before I let you go. Let's say, a patient was seen by in a center by someone like you, started on this drug, and then now is seeing their general GI, the general peds, etc. What are the things we should be looking for while this patient is on this medication? What should trigger, this needs a referral back to a short bowel rehab center? What are the things, what are the advice you would give for the general gastroenterologist out there?
There's an outline specifically about what labs to monitor. We get some of these labs regularly on patients who are getting TPN. So the standard electrolytes, liver function panel, or rather hepatic function panel. We also should look at amylase and lipase, which is something we may not check quite as often. We also check for Hemocult, at least annually, for that. And we're checking for amylase and lipase because there is risk of pancreatitis in some of these patients. These patients may have worsening biliary disease. For instance, if they have gallstones, they could potentially have worsening jaundice. So these are the reasons we are, with their labs, looking at their bilirubins, looking at amylase and lipase, looking at any signs that they could be obstructed. GLP-2 is thought to enhance intestinal adaptation. So you have increased absorptive capacity of the intestine. As a result of that, you can have increased growth of a stoma. You can almost have an obstruction potentially if you have a patient that has a stoma and is on this drug. So you look for obstructive symptoms. The reason we do the Hemoccult, at least annually, is you're looking for polyps. In pediatrics, when we think about polyps, we think about those juvenile polyps. But, for this drug, it's enhancing intestinal adaptation. So you potentially could have polyps develop. So screening for that, and these patients 1 year after therapy need to have a colonoscopy done. And potentially at the time of starting the drug, if there's already unexplained blood loss rather, in order to be able to know the status of their colon. And then, even if you don't, if they're not following regularly with the IRP center, telemed has made such a big difference for being able to communicate and to work with families. And perhaps they, once a year, they do still need to see that center who maybe has a little bit more expertise. But building a relationship with an IRP center, one of these multidisciplinary centers, is I think, very crucial. Everybody can't come to some of these centers. People don't always have the resources, unfortunately. And I think that telemed has made a big difference with that. And I think trying to work and identifying somebody in that program that or somebody you can reach out to who's willing to help you is also a very important aspect of this.
Well, now I have your cell phone number, so I know who I'll be reaching out to. Well, Dr. Corin, thank you so much. This was very helpful, really, put this in perspective, understand who is at risk for short bowel, recognize short bowel, recognize the symptoms, do the workup, and what kind of therapy we need, and the multidisciplinary approach, and what to look for in our patients who are on FDA-approved therapy, tetraglutide for short bowel, as a general GI person, or somebody in GI who has a different focus. And I absolutely agree, is having a resource, yourself or other colleagues that could see those patients, get them evaluated, kind of give us guidance, and then for the rest of us be able to follow these patients and be familiar with when do we need to refer back, when do we need to start something new. And I like the fact you say when the patient feels stuck, and I think that's in everything. If you're stuck, you're not moving forward, time to do something different and call the experts. So absolutely appreciate you being part of our Monday Night IBD Consult with the Expert today. And thank you so much. And I cannot wait to talk to you more about this topic during another video session.
Well, thank you for having me.
For everyone who joined us today, thank you so much for being part of the Monday Night IBD family and being part of this program. Please make sure you claim your CME credit by scanning the QR code in the video screen or by clicking on the link in the tweet below. Thank you, everyone.